I think so.
Okay. We'll go ahead and get started then. So welcome everybody to the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central AHEC, and you can see our department's mission statement listed there for you. Next slide. So we just want to take a moment to thank everybody for joining us. And if you could please make sure that your microphone is muted as we get started here. Also, if you can help us, if there are interaction or questions from our presenters, if you could be engaged in the session. And then if you want, you can put questions in the chat box. And then also towards the end of the session, if you could help us out, I will put a link in the chat box for feedback. So please help us out with those things. Next slide. And those who are claiming CME credit, please make sure that you get this code here, and you'll want to text the word attend and then this code to the toll-free number listed there. Just make sure you do that before midnight tonight in order to receive your credit. Next slide. If you haven't registered yet, I'm sure everybody with us right now probably has, but if you haven't, you'll need to text your email address to that same number. And then from there, you should be able to claim your credits with the instructions that I just shared previously. So any questions, please feel free to reach out to me. Next slide. And if you are claiming credits, please make sure to check your transcript with the CME office. You can go to their website and make sure you open that and take a look at it so that we can make sure you are receiving the credits for the presentations you're attending. But if you have questions, you can reach out to them. Their information is listed there, or send me an email or a phone call. Next slide. Those transcripts are needed if you are a member of the AAFP and you are interested in claiming credit through their system. You'll just need that transcript, and then you can submit that to them in order to claim credit through their system. But if you have questions, again, contact them, or you can reach out to me as well. Next slide. It is also our goal to meet these nationally established physician core competencies, and those are listed there for you. Next slide. And so we just want to mention that all of our presenters and their preceptor have no financial relationships with ineligible companies to disclose. And they are going to be giving us a presentation today. It's Dr. Perez, Donas, Dr. Ramos, and their preceptor is Dr. Amati, but the topic for today is going to be calibration and discrimination of the Framingham Risk Score and the Pooled Cohort Equations from the AAFP poem. So I'll let them get started with their topic.
Great. Thanks so much, Nicole. So like she said, we're going to be discussing the calibration and discrimination of the Framingham Risk Score and the Pooled Cohort Equations. I'm Alexis Ramos, and I have Melanie Perez Doñez here with me, and our preceptor was Dr. Amati. So I'll pass it over to Melanie.
Hi guys, I hope you can all hear me. So yes, like they both mentioned, the title of our article or poems is The Calibration and Discrimination of the Framingham Risk Score and the Pooled Cohort Equations. The objectives of this article or research were one, to assess the calibration and discrimination of the Framingham Risk Score and the Pooled Cohort Equations in Ontario, Canada. Number two was to appraise the validity of these risk scores in pre-specified subgroups to gain additional perspective on these risk assessments. And number three, to analyze the need for further refinement of the cardiovascular disease risk prediction scores. All right, just a little bit of background of, I'm sure we're all very familiar with this. We do this on a daily basis when we're in clinic and sometimes in the hospital as well. But atherosclerotic vascular disease, or ASCVD, as we better know, is common in the general population. It affects the majority of adults past the age of 60. It includes four major areas. One of them is coronary heart disease, CHD, which is manifested by fatal or non-fatal myocardial infarction, angina pectoris, and or heart failure. The other area that's included is cerebrovascular disease, which is manifested by, again, fatal or non-fatal stroke and transient ischemic attack. Peripheral artery disease, which is manifested by intermittent claudication and critical limb ischemia, and aortic atherosclerosis and thoracic or abdominal aortic aneurysms. More about the ASCVD, some of the risk factors, and again, we're very familiar with all of this, include hypertension, diabetes, cigarette smoking, history of premature family history of ASCVD, chronic kidney disease, and obesity. And this little picture here on the side is just the ASCVD risk estimator that we use with some of the things that we need to, input there to get that or calculate that estimate risk. All right. This is more related to the article that we are going to be talking about. It's focusing on primary prevention in cardiology, and as I mentioned before, most of us know primary prevention in cardiology around the world have endorsed the use of risk prediction scores to estimate the risk of atherosclerotic cardiovascular disease in our patient population. In Canada, the Canadian Cardiovascular Society recommends the use of the Framingham Risk Score. And in the US, the American College of Cardiology or the American Heart Association recommends the use of Pooled Cohort Equation. And both of these are the ones that this article mentions, and we'll try to go into a little bit more here in a second.
Perfect. And while these two are the main ones that are discussed, it's important to mention there are many risk score calculators out there. So these are just the two that we're gonna focus on.
All right. The first one, the Framingham Risk Score, it was assembled more than 3 decades ago. It was initially developed using the data on individuals residing here in the States in Framingham, Massachusetts. They used traditional risk factors categories, which included data mostly from the decades of the 1970s and 1980s with long-term follow-up. And they predict the cardiovascular event, but they did not consider the potential competing impact of non-cardiovascular deaths during that follow-up period. Some of the variables included with this risk score included age, gender, the total cholesterol, the HDA cholesterol, their systolic blood pressure at the time of the visit, if they were on any treatment for blood pressure, the diabetes, if they have any diagnosis of diabetes, and their smoking status, if they were current smokers or not. And then the key variables that were excluded were if they were on any treatment for blood pressure, and also family history of CVD. This picture here on the side is just what you would come across if you were to do this risk score, this Framingham Risk Score, the things again that you will need to input to calculate that risk. The endpoints assessed by this risk score, the Framingham Risk Scores, were the CHD death, the non-fatal MIs, coronary insufficiency or angina, the fatal or non-fatal ischemic or hemorrhagic stroke, transient ischemic attacks, and intermittent claudication or heart failure. And now moving on to the next risk score that we will discuss. This article again talks about is the one, the ACC AHA or AHA. Pooled Cohort Equation is the one that we use here in the United States. It was developed from several United States cohort studies that included different calculators from white individuals and for Black individuals. Oh,
I'm sorry.
Go back. It's okay. Yeah. The outcomes of this risk calculator were limited to both fatal and non-fatal CHD and stroke, and as you know, in comparison with the other one that had more things that they looked into. And beginning in 2013, the ACC AHA Pooled Cohort Heart ASCVD risk scores were recommended for use here in the United States. Ever since 2013, this is the one that we mainly use here in the States. All right, next one. And with this cohort equation, the variables that were included were age, between the ages of 40 to 79 years of age, their gender, total cholesterol, HDL cholesterol, their systolic blood pressure, their diabetes diagnosis, if they're current smokers. And then the things that were excluded from this equation were the family history of CVD. The endpoints assessed were again CHD death, but non-fatal MI, fatal stroke, and non-fatal stroke. Now, talking about our study, this is just kind of like a description of what this the specific study that we looked into was all about. So first, it was an observational study of Ontario adults to evaluate the calibration and discrimination of the risk prediction scores I have mentioned. They used the EMERALD, or Electronic Medical Record Administrative Database, to identify the study cohort. And then the end goal was they used a database that included more than 350 primary care physicians and more than 500,000 individuals in Ontario, Canada. Talking about the study cohort, for this study, the inclusion criteria included individuals between the ages of 40 to 79, and this was to reflect mainly the newly developed pooled cohort equations that the ACC and AHA were recommending. They included those who visited their primary care physician from January 1st of 2010 till December 31st of 2014. And they included those individuals who had had blood pressure and cholesterol measurements taken within a year of each other. Okay, now continuing with the cohort, the exclusion criteria for this article or this study were patients with prior hospital admissions for the following: the myocardial infarction, CVD, heart failure, peripheral vascular disease, coronary revascularization from 1988 to the date of the individuals entered the cohort study, patients that were non-residents of Ontario, those without a valid Ontario health card, and individuals whose PCP had been enrolled in EMERALD for less than 1 year. And here on the right, we can see one of the pictures from the study. It's kind of like the same description I already went over, just a little bit prettier for you guys to follow. Yeah, the exclusion criteria. And then at the end, it says the main cohort. That was the total number of patients included in the study.
So now that we kind of had the setup for the study, we kind of have to have a little bit of definitions to fully understand kind of what they were looking for, the outcomes. So the Framingham outcome definition, it included a composite of circulatory death and hospital admission for MIs, angina, any CVA events like ischemic stroke, hemorrhagic stroke, a TIA, heart failure, peripheral artery disease, which included a AAA and a carotid endarterectomy or stent. That's what they were looking for in the outcomes. The pooled cohort equation outcome definition included a composite of death due to coronary heart disease and stroke and hospital admission for non-fatal MI or stroke. So these cohorts were followed up until either the completion of the study, until they have had 5 years of follow-up, or until death from a cause unrelated to cardiovascular disease, or until the endpoint had occurred. How they performed the statistical analysis was by calibration and discrimination. Calibration refers to agreement between observed and predicted risk. Discrimination is how well the model differentiates between different risk levels. So this study compared 5-year predicted and observed rates of the atherosclerotic CVD using equations already mentioned and the baseline survival function at 5 years, which is important to note. So this graph shows the discrepancy between the predicted and observed 5-year risk for Framingham and the pooled cohort equations, respectively. The 5-year predicted, you can see that compared with the observed is not congruent. The solid line shows when the predicted risk is equal to the observed risk. So they evaluated the accuracy of the risk scores in pre-specified subgroups to evaluate whether there were discrepancies in the discordance ratios, which we just saw. And they compared the 5-year predicted and observed rates of atherosclerotic cardiovascular disease in different risk categories. So the Canadian Framingham Risk Score categorization 10-year risk and the US Pooled Cohort Equation categorization 10-year risk. An additional multiple imputation analysis using 10 imputed data sets for smoking status as well. And they repeated the analysis in a statin eligible cohort according to the 2016 CCS guidelines. So that included individuals aged 40 to 75, those who did not have diabetes, whose LDL cholesterol was less than 5, those who did not have CKD, and those who were not taking statins. Excluded were individuals with substantial comorbidities like history of cancer and receiving hemodialysis. So these are just the additional analysis they performed. So it is important to note that going back to this slide, the Framingham risk, it shows that it had an over 110%, what do you call it? Over prediction of cardiovascular disease. I think it's important to note in this study that they had some limitations. The limitations of the study included the population. It's important to note that this took place in Canada, in Ontario, where the population may not be predictive of, all of the US, as well as it's important to note that the Framingham risk score was developed in Massachusetts back in like the 1930s. So that also does not really have a model that is congruent with cardiovascular risk today. And then they only followed for about 5 years, but did not have 10-year follow-up. So I think additional follow-up of the cohorts would be needed to ensure findings can be extended over a longer duration. Also, information on the way the blood pressure measurements were obtained in this study was not really available. Blood pressure readings in clinical practice usually are higher than the research setting. And so this could have also contributed to an overestimation of the risk. And then a modification of the Framingham risk score doubles the risk if there's family history of premature atherosclerotic cardiovascular disease. And it looks like they didn't factor in family history, but even if they did factor in family history, that would actually lead to further overestimation. But it's important to note that family history was not taken into account as well.
And let me just add a little bit for that. There's some graphs that were included in this article. There were just too many for us to put in the presentation, honestly, which we should have, just for you guys to visualize. But one of the things that there is a table number 1 that kind of puts into groups like what they did, like the age, the residency, ethnicity, and things like that, the measurements, the cholesterol measurements, and things like that. Under ethnicity, they only included Chinese population, those of South Asian descent, like ethnicity, and also Black ethnicity. Also, another thing to kind of like keep in mind, and the reason being is because that's not the typical population that we would mainly deal with here in the US. Those are more specific to the Ontario, Canada population. And the total number of cohorts or participants in the study, we're not really sure where the rest of the population is. For example, for Chinese population or ethnicity, there were about 2,000 patients. The South Asian were about 1,500. And then for the Black, about 1,000. So less than 5,000 cohorts or participants were accounted for ethnicity, and the rest, this research does not mention where the rest of the population came from, or the participants came from, which is kind of strange for us. Something just to keep in mind. Yeah, that was the main thing I wanted to add to the limitations of the study.
Yeah, I think that's also really important to note as well. So just kind of taking it all into context of why does this matter to me and my clinic practice? The first thing that is demonstrated by this study is that the Framingham Risk Score somewhat overestimated the risk among individuals in younger age groups, and then the Pooled Cohort Equation overestimated risk in older age groups, but essentially both overestimated in populations. This creates a need for additional validation studies across Canada and as well as the United States here. Evidence of consistent overprediction would strongly support redevelopment of prediction risk scores for atherosclerotic cardiovascular disease to improve treatment decisions. And the overall point that I took from this is that we just need to continue make shared decision making with our patient based on the therapy modalities that we have. I think it's important to take the risk from what the calculators are saying and discuss that with your patient and see what would be the best treatment for them. Mostly statin therapy. Is it risk versus benefit decision making with them? Do you have anything to add, Melanie?
No, that's mainly it. I was trying to get more information. This is a very short article, so our presentation is not the longest, but there's other ways to assess for patients with like comorbidities and the risk for atherosclerotic vascular disease, kind of like including like the oh my goodness, the coronary index, the calcification index. That's another way to assess if the patient is in need of the calcium index score, to see if the patient is going to need some sort of therapy prevention. But yes, this study did overestimate, and the percentages are quite high. So for example, for the Framingham, the risk score, it overestimated them by 101%. It was the Framingham risk score overestimated risk by 110% in men and 85% in women. And then the Pooled Cohort study overestimated by about 115% in all individuals. So it didn't really, there was no difference between men and women. But there was, overall, there was more like significant changes or overestimation, mainly in women over men. But yeah, it's just, I feel like, yes, I agree. Just keep in mind that, again, there is many risk stratification scores are there, and it's just going to end up being a shared decision making with your patient based on family history and their comorbidities, if they will benefit from statin therapy or not.
Yes, I agree. And also life expectancy as well is important to factor in. And then when we were doing the research for this presentation, we found it interesting that Europe actually has an entirely different risk stratification that they're using. The European cardiac risk stratification that they find may overestimate less the atherosclerotic cardiovascular disease. So I think looking also if we need to maybe adapt what the Europeans are doing as well. Oh, what I also wanted to mention was this study also took place in Canada, where the medical model of practice is different. They have the universal healthcare. So kind of comparing the Canadian risk population to our risk population, where we may not have that much access, could also play a portion in the model that was assessed. These are our references. And I guess we'll open it up to any questions or comments, concerns from the audience.
Was there any mention of the risk of taking these statins in these populations? Did they mention anything in regard to the risk benefit? So since this is overestimating the risk of not taking the statin, did it have any comparison of taking this statin and having side effects?
No, I didn't see any information whatsoever on that.
Yeah, and I don't think they kind of touched on statin therapy at all. It was more so like, this is your risk of possibly having an atherosclerotic event, and this is actually what happened. Like, did you actually have an atherosclerotic event? And it's saying that it overpredicted your ability to have that by quite a lot. So then it's like, what do we do with the statin therapy? But that's a really good question. I think we have a question in the chat. Let me see. It says, do these organizations have plans to revise their risk calculators to reduce overestimating risk? I think also great question. So there is a lot of studies that are saying that the Framingham and the ACA and AHA calculators are overestimating, but we just need more data to refine that and say, okay, we actually need to get together and, start tweaking the risk stratification tools. So I'm sure there are organizations that are trying to do that. Do you know, Melanie?
I am not really sure if there's any. I know they're definitely, like you mentioned, they want more information to see where or what things need to be modified in order to get a better estimate of the risk. But this article does not mention that these two particular entities are in the process of refining there. It just says that there needs to be more data, more information to do so. So at this point, like I said, like we mentioned, it's going to be based on like that discussion with your patient, and maybe utilizing any other tools out there to assess for that risk of the ASCVD event.
Yeah, and also pill burden, adding another pill, is this going to really benefit the patient? I think taking the scenario that you have in front of you based on your patient care is going to be really important, especially that we know and we're conscious that these risk scores may be actually overestimating your patient's risk. Okay, well, thank you guys so much for your attention. We appreciate it. And
Great job, guys.
Thank you, everybody. Thank you also for presenting to us. We really appreciate it. I will be sending out an email to everyone after this with the evaluation link. I made an update, so I will send that out to everyone here shortly this afternoon, but we appreciate everybody in attendance. Thank you.